Good afternoon. On behalf of Sri Lankan Association of Geriatric Medicine, it is my great pleasure to welcome you all to the monthly CME program of it's an important event in our calendar, and we always try to discuss new topics and clinically relevant areas related to geriatric medicine and all the medicine subspecialties as well. So today we have a distinguished panel led by Dr. Niranjan Disanayaka, consultant in respiratory medicine in Teaching Hospital Kaluthara. He's also a past president of Sri Lanka College of Pulmonologists and a good friend of Sri Lankan Association of Geriatric Medicine. And I would like to warmly welcome him to introduce the panel, and I would like to thank everybody for taking their time to participate as panelists in this important discussion on tuberculosis in older adults. Over to you, Niranjan.
Thank you very much, Shamilam, and I think it is a great honor to be here on your invitation, as well as the Association of Geriatric Medicine in Sri Lanka. A new specialty, but I was part of your annual academic sessions, and it was brilliantly organized. Congratulations, and happy to be part of your probably the last CME during your presidency. And we will plan to work together in the future as well. So without any delay, let me kindly introduce our panel, distinguished panel, Dr. Pramudita Veerasinghe, consultant in nutrition, consultant nutrition physician from Teaching Hospital Kaluthara, Dr. Namal Veerakone, consultant geriatrician from Teaching Hospital Kaluthara, and then Dr. S. Sadganandan, consultant geriatrician from Teaching Hospital Kaluthara, Dr. Sarah Pereira, postgraduate trainee in tuberculosis and chest diseases, and Dr. Navodha Jayasekara, postgraduate trainee in diploma in tuberculosis and chest diseases to the podium. And you will notice that it is a Kaluthara orientated panel that we have. Actually, we had this panel discussion in Kaluthara as our initial discussion, and that's why we decided that it is a very important discussion that we have to take it to the national level. And thank you very much again for providing us with the opportunity. Yes, please have a seat, Sarah. Okay, so without any further delay, we will go to the presentation. Yes, so tuberculosis is a significant conundrum, a medical issue currently that is affecting Sri Lanka, with around, unfortunately, around close to 900 deaths per year, even though it's a completely curable disease where the National Program of Tuberculosis and the government of Sri Lanka provides anti-tuberculosis treatment and management of tuberculosis free of charge. We still have a huge amount of deaths and suffering due to tuberculosis in Sri Lanka. And a special group that needs specific attention is the elderly patients, and you will see why we have decided to discuss this topic when we go through the slides. And so let me start with a case history, and I think Dr. Sarah will start the presentation on a case of delayed diagnosis.
So this is a 77-year-old patient who's diagnosed with diabetes, dyslipidemia, hypothyroidism, who's been previously investigated for pyrexia of unknown origin at a tertiary care hospital. And after extensive investigations over a period of 4 months, she was noted to have a sputum gene expert positive for Mycobacterium tuberculosis. So on admission, she presented with on and off low-grade fever with occasional cough and loss of appetite. No contact history of tuberculosis. Social circumstances-wise, she had a good family support and accepted her condition well. On examination, her BMI was low, 14.7. Investigations-wise, the inflammatory markers were raised initially, ESR, CRP, and liver functions were marginally elevated, and the diabetic control was poor. So an endocrine referral was made to optimize the diabetic control, where she developed vomiting with metformin, and due to the same reason, we had to gradually introduce anti-tuberculosis treatment as well. A nutrition referral was made where a high-protein diabetic diet was recommended. The patient was started on anti-tuberculosis treatment on a slow desensitization basis because of the transaminitis and the deranged bilirubins. However, ultimately, we were able to start the patient on fixed dose combinations with the first-line agents.
Yeah. Thank you very much, sir. Now, this is basically a typical history of tuberculosis that we present. So that is why we have taken it as a first case. And we know that there is a significant lack of diagnosis, a delayed diagnosis in patients with tuberculosis. And in the elderly, it is more. So the first one that we would like to discuss is that these patients are basically have multiple comorbidities, and specifically when we are commencing on anti-tuberculosis drugs, there are a lot of drug-drug interactions in these patients. So one of the important things that we have identified is that especially metformin, we know that usually anti-tuberculosis drugs can cause a significant degree of vomiting, and at the same time, if we give drugs like metformin, it enhances the vomiting effect, and sometimes when the patient has vomiting due to metformin per se, sometimes when we additionally give anti-tuberculosis drugs, they have increased vomiting, and as we know, vomiting is a reflex, and especially when they associate vomiting with anti-tuberculosis drug, it's really difficult because there are two things. The patient will not tolerate anti-tuberculosis drugs, as well as if the patient vomits soon after giving anti-tuberculosis drugs, then the effective dose of absorption is not there. So there are two things that we have to be very careful about. So what we usually do is we sometimes give the metformin and anti-tuberculosis drugs separately for these patients who are having vomiting, and sometimes the patient complains of nausea, we preemptively start an antiemetics in the early stage of treatment so that the patient will be tolerating this anti-tuberculosis treatment proper, and then we go according to the patient's picture. And the second thing is sometimes, especially these patients, as you saw in this patient, the BMI was about 14. They are almost malnourished. And on top of that, whether the need for metformin is there. So we discussed with the endocrinologist regarding whether the metformin is needed and whether we can convert into a certain other drug until the patient is having adequate BMI or the tolerabilities there. So that is how we do. And the other end of the spectrum is, I think you will agree, most of these patients with a low BMI malnourished have a very poor hepatic reserve, and especially when you give drugs like glycoside, they can go into hypoglycemic attacks very quickly. That's the other end of the spectrum. So sometimes we are very careful in giving glycoside for these patients with tuberculosis as well as diabetes together. Even when the endocrine suggests glycoside, we are a little bit cautious, and we are going into a low dose as well because they have renal impairment on top of the diabetes that they have. So these are the important things. So anti-tuberculosis intolerability with oral hypoglycemic can be due to conditions such as vomiting and nausea associated with the combination, and at the same time we have to be a little bit careful about the interaction about hypoglycemia as well. And the second important thing is, as usual, we are fighting to get a proper diagnosis at the correct time in patients with tuberculosis, because correctly diagnosed tuberculosis at the proper time is completely curable and without major side effects in the context of having, in Sri Lanka, having low HIV prevalence as well as a low multi-drug resistance and extensive drug prevalence in Sri Lanka. But I think Sat will answer the question. In this patient, Sat, I think there was a delayed diagnosis, even though the patient was extensively investigated in almost a tertiary care hospital. There was a delay in diagnosis in this patient for 4 months. What factors would have contributed in this patient?
Good afternoon, all of you. It's my pleasure to be here and see you all. And I would like to thank SLAGM and Dr. Niranjan, consultant pulmonologist, and their team to arranging this sort of program. And I'm happy to be part of this. And we will come to the case. It's not in Sri Lanka. It's commonly all over the world. It's delaying tuberculosis diagnosis in the older patients. The causes are, you can categorize as disease-related factors and also patient-related factors, as well as delay in healthcare factors. So basically, immunosenescence, that means when you're getting old, your immune system, the reserve is deteriorating. So with the time, you are losing, working against infection. So basically, the macrophage activation and the cytokines and the T lymphocyte basically losing their efficiency. So that's a reason the older people are more susceptible to get this sort of infection, especially in the tuberculosis. That's why that the demand to test also most of the time falls negative. So we can rely on MANT test. When you see the other factors like, what textbook saying that TB patient coming with productive, persistent cough, night sweats, loss of appetite, loss of weight, which is you can see in the younger patients, but it's a different scenario when it comes older patients. Because they most of the time presenting with that atypical nature, like fatigue, generalized weakness, loss of appetite, and delirious state and falls and functional deteriorations. So because of this nature of this disease condition, we may not able to initially suspect, tuberculosis when it comes differential diagnosis. And also when you get the chest images that upper lobe involvement with, cavitary lesions, which is common you see in the younger population or younger patient with TB. But when it comes older people, it may affect, middle and the lower lobes and phalangeal lesions. So sometimes we misdiagnose or sometimes miss this tuberculosis in the initial stage.
Yes, Seth. Now, basically, I think you have highlighted the important disease-related factors in this patient. So, when we look at this patient, actually, now this patient has had a 4-month history at, investigate. He has had a good family support, and when you look at the chest X-ray, it's almost like a left upper lobe typical tuberculosis. But even there, we have a disease delayed diagnosis in this patient. So, probably maybe the symptoms were probably, as you said, maybe was a little bit atypical. She complains of loss of appetite, loss of weight. Maybe the chest X-ray was not taken at the initial stage. They have been investigating for high ESR, and even the chest X-ray was done, as you correctly said, in the healthcare factors. The availability of testing. Sometimes these patients find it difficult to give a sputum sample. So, and we know that the sputum AFB, which was the previous gold standard of diagnosis, has a low yield. They had, and the other thing is that there might be a little bit of delay, isn't it, in this patient? Yeah.
When you see our patient, 77-year-old
Yes.
with the diabetic and hypothyroidism, and also this patient, might be having sarcopenia and there is a frailty, then symptoms might be overlapping when it comes with loss of appetite, loss of weight. It mentioned, I remember, it's on and off fever,
Yes.
not persistent cough. That's why the low-grade night sweats, what we see in the younger population is not in the
Yes.
older population.
Yeah.
And they are not able to produce much sputum because of, the cough reflexes are very minimal. Okay, then also this disease is nature in the postbacillary.
Yeah.
Even if they produce sputum, you're not able to,
Yes.
most of the time it's a sputum negative.
Yeah.
So then you have to rely on molecular, test
yes.
and bronchoscopy, which is not available in each and every setup. And other factors, mainly those are the factors in
Yes.
our patient, but I would like to also highlight, just go beyond that, our patient. And they will have patient-related like mobility issues and, transport issues and, the social background. Maybe someday those patients are older people living alone, and most of them maybe resides in the care homes. So always they are rely on caregivers. So when the caregivers available time only, they are able to come to hospital and clinic visits and all.
Yes.
So
And
those
I
are the
think
factors.
one of the most important thing, as Sat correctly said, is that when you see a patient we are suspecting tuberculosis, especially with this type of a radiograph, even a negative sputum AFP, please don't say excluded tuberculosis. Even if the gene expert is negative, because even if the patient's gene expert is negative, always think about the possibility of tuberculosis in these patients and order a second sample, properly taken sputum sample from their patient, or else refer this patient where the bronchoscopic facilities are there. And we are happy to do bronchoscopic BALs in these patients to get a correct diagnosis, because these patients have sometimes, in the context of diabetes, they can have cavitatory fungal infections, they can have atypical bacterial infections, which should not be treated as tuberculosis, and sometimes rarely they can have cavitatory malignancies with secondary infections, which can mimic exactly like this. So need to have a bacteriological confirmation. The current gold standard is nucleic amplification tests, and which is available in most of the hospitals, and it is within about 1 or 2 days you should be able to get a sample. So if that, even if the patient's sputum AFB is negative in such a patient, please repeat the sputum AFBs again and again, and at least get a sputum gene expert once or twice. If not negative, still have a high suspicion, refer this patient for a bronchoscopy and a BAL so that we can confirm the diagnosis. And as Sat has correctly identified a lot of factors, limited mobility, transport difficulties, which hopefully we will be able to bring into light during the next few patients which we have been discussing.
I would like to highlight, we highlight here the no contact history.
Yes.
Because of immunosessions, most of the older people are reactivation of tuberculosis, not the new infection. So it's pointing out that
Yes.
TB, no contact history is not much reliable when it comes older people. And also want to say that most of the patients are with multiple comorbidity, heart failure, and already they have COPD, bronchial asthma, and they are, with the stroke and the Parkinson disease. Most of them, they come with the lower respiratory infection. What we read, first read aspiration pneumonia or heart failure. Even there will be, pleural effusions also, maybe extrapulmonary TB also, which is common relatively in older people.
Yes.
So sometimes we miss. So what we can do here is the best thing to review the patient, and also advise go to same, if it is general practitioner, the same general practitioner. When sometimes you read it for lower respiratory infection, then they might go to next GP. Then again, there is, newly they started antibiotic,
Yes.
and there is more delays.
I think the follow-up should be arranged. Even if this patient was actually discharged from that tertiary unit, ideally within about 1 or 2 weeks, we should arrange a proper follow-up of this patient so that we will not miss this patient. And I think if we had to highlight a very important point Sat has pointed out, even in younger patients with tuberculosis, a contact history, especially less than 5 years, is a very significant factor. But in the elderly, as you will see, it is not an excluding factor, because most of them probably would have been infected about 20 years back and now having active disease. So about the nutrition assessment, I think we permitted that this patient has a BMI of about 14, and most of our patients are like this. Most of all 5 patients actually have low BMI. So how would you address low nutrition assessment in this patient?
Yes, Niranjan. Now, first of all, it's not unlikely, not an uncommon thing to see these kind of patients, because they have been treated multiple times in the private sector, or people most likely will not look into the nutrition aspect of their diet or anything, rather than looking into the management part, symptomatic management. So first thing, if you look at a patient like this in the ward, chest ward or oncology ward, we have patients like this. So number one thing you should look into is whether this patient is having a risk of going into refeeding syndrome, which is one of the most important topics that we are going to discuss in the subsequent lectures. But due to time constraints, I will discuss about the brief nutrition care process, what we do when we are being referred with a patient like this. So first thing is actually we get the history of the patient, especially in related to the diet and the symptoms which can likely interfere with our nutrition management. For example, diarrhea, constipation, nausea, vomiting, abdominal bloating kind of symptoms especially. Then next thing is the anthropometry. Weight is the main thing that we measure. When we talk about the weight, there are like 3 main things: the usual weight, actual weight, and the ideal weight, right? The actual weight is the weight that you measure. You put the patient on the scale, and the measurement that you get is the actual weight. But the patient might say, today I'm 40, but I used to be 50. That 50 is the usual weight, that the last known weight of the patient. So what is the ideal weight? Ideal weight is the weight that one should have for that patient's BMI to become 25, right? So the usual weight is a history. Like in the history, if there are postgraduates here, I think there are. So your history taking, you should ask that question, what is your last known weight? Actual weight we can calculate, and the usual, ideal weight, we have to calculate the actual weight we can measure, right? So the anthropometric BMI, then another calculation that we arrive at looking at the height. There's certain investigation, all the investigations that everybody does is important nutritionally, serum creatinine, full blood count for hemoglobin, any other special investigations we do for micronutrient levels. Everything is important, especially in these kind of patients. And nutrition focused physical examination is something that you do from head to toe to looking at the specific nutrition deficiencies. Nowadays, hair loss, if the patient is having hair loss, alopecia, we suspect of a zinc deficiency, and more important, the vitamin D deficiency, which is quite common. More than 90% of the population, females in Colombo, are having vitamin D deficiency, according to a study done in 2024, very recently, right? So from head to toe, any like vitamin B12 deficiency, any neurological signs which suggest that the patient is having pyridoxine deficiency, like peripheral neuropathy, which can have with isoniazid and socioeconomic state and the functional behavior quite naturally. Then can we move on to the next slide, please? Okay, now this patient being a diabetic patient, I will first discuss the nutrition provision of a non-diabetic patient. What we do, we calculate the calorie intake using a weight-based calorie measure, that is 35 kilocalories into weight, 35 into weight. So we divide that to carbs 60% and fat 25%, maximum 25%, and the protein 15%. If we want more protein, what we do is we can increase the protein intake, and comparatively we cut down fat. Like, let's say protein we need to increase to 20%, we cut down fat to 20% and protein 20%, altogether 100, right? In diabetes, what we do is, the problem is carbs, right? Diabetes, we cut down carbs from 60% to 50 to 55%, and proportionally we increase the protein. Protein is not a problem, right? And moderate fat with high fiber. So high fiber foods, the best high fiber foods we have highlighted here: chickpea, cowpea, and green gram. 1 cup has about 10 to 11 grams of fiber, the highest fiber containing foods in Sri Lanka, right? 1 cup has a protein intake, protein amount of 6 to 7 grams, that is equal to an egg, right? So good option for vegetarians, again. So then come to the physical exercise for hyperglycemia patients who are having generally high blood sugar levels. What we address them to walk about 100 steps inside the house after a meal. After a meal, don't just lie down, sit down, just walk 100 steps inside the house. That is to stimulate the muscle function. When you have your muscle functions, the blood sugar will get into the muscles, so the blood sugar response will be retarded, right? So thiamine is again very important. I will discuss in a subsequent lecture to prevent refeeding syndrome, right? So can we move to the next slide, please? Then.
So thank you very much. I think in this case, I will not say case, this patient history, and what we have identified is that tuberculosis in the elderly, even when the patient is having good family support, the patient has been brought to the relevant hospitals, tertiary care hospitals, but sometimes because of the atypical presentations and the lack of investigative facilities, probably lack of knowledge regarding the investigation facilities, might cause a delay in these patients. The first thing, hence in a patient who is admitted to the wards, it's very important that we know the proper investigation facilities that are available and order them, and one investigation being negative doesn't exclude the diagnosis, and we have to go behind the diagnosis as much as possible, even going into invasive procedures in an appropriate patient to get the proper diagnosis and initiate proper treatment. So they have multiple comorbidities like these patients. They might have drug-to-drug interaction, especially tuberculosis and diabetes being common together. Each will have interactions with each other. Addressing these at the earlier stages will improved compliance of the patients as well as good outcomes of the patients. Proper nutritional assessment, as Pramudita said, going for a very good history, going for the ideal weight, looking at the physical examinations to identify deficient features, especially like peripheral neuropathy, where diabetes can also contribute, and treatment, when we are starting in INH treatment, also it might be a very important factor where we will have to increase the pyridoxine doses in these patients. So that is also a very important factor that we have to contribute. And a very good, I think, message about chickpeas, not only for these patient groups, probably for us as well. So high fiber, high protein content, especially for the vegetarian, that will be a good option, especially in a breakfast meal, isn't it? Right. So why? The next question is, I wanted to highlight with this one, and that's why we took a little bit of more time for the first case, a simple case, but highlighting the most important aspects. So this will help you to identify some problems that we face when we are managing tuberculosis. Is it the problem that we only face, or is it a problem that as a country that we face? And that is what we are looking at, the importance of these patients, right? So these slides, was kindly provided. Some of these slides were kindly provided by Dr. Mizaya Khada. With her permission, I'm using some of her slides. And so when we look at the tuberculosis number of Sri Lanka, this is the 2025 data. We have diagnosed 8,726 patients. But according to the calculation, we should have at least 14,000 patients. And there is a lack of about 5,000 patients being diagnosed. And we have shown that this gap might be in elderly patient population because they are not diagnosed, and probably they are dying at homes and elderly care homes, and maybe in the roads without us knowing that the patients are having tuberculosis. So they might contribute with the gap. And around in Sri Lanka, unfortunately, we have about 8,000 cases which are being diagnosed in patients. And when we look at these 8,000, about 24% of them, that is one of each 4 of tuberculosis patients in Sri Lanka, are currently more than 65. So 1 in 4, even though the population is about 18% at the moment, more than 65, but 1 in 4 patients is more than 65. And if you take the more than 55 group and add it, it is almost 50%. That means 1 in 2 patients of tuberculosis in Sri Lanka are more than 55. And that is a very important factor that we have to consider. And it keeps on rising. The green is that in 2015, you see that as the age increases, there is a slight reduction in the incidence. But in the blue one, 2019, it is there. But in 2025, we can see that the case number is rising in more than 65. And maybe we are facing a huge problem. I think Rochana will agree and Shamila will agree. We have most of the, I think if I am correct, in the next 25 years, more than 50% of our population will be more than 60 years, including us. So yeah, that will be a huge problem in the future. And this is the population demographics. We can see that from a bottom-heavy graph, we are going for a top-heavy graph. The demographics are changing. Hence, we'll be facing a huge amount of tuberculosis patients who are there in the community in future. And unfortunately, in Sri Lanka, the WHO rate that we had to achieve is 90% of treatment success rate. But at the moment, we are only achieving 79. That's 80% treatment success rate for tuberculosis, even though we have very good treatment facilities in Sri Lanka. And majority of them, because of the high death rates that we have, in Sri Lanka, we at least lose about 900 people per year due to tuberculosis. And when you look at this, when you look at the treatment success, the low treatment success is contributed by the 65 plus age group. They have a low treatment success rate, about 72, compared to the national average rate of 79%. And one of the major reason is the high deaths among this age group. So even though 24% contributes to the tuberculosis burden of more than 65s, 50% of the deaths are in the more than 65 age group. And if you take the 55 to above group, 75% of the deaths are due to in this age group. So that is a very important significance in these patient groups. And the case fatality rate is almost twice in the TB group, in the more than 65 age group, compared to the overall mortality rate is about 8% in that group. So we have a huge problem. That means The number of tuberculosis patients are disproportionate in the 65 plus age group. Number of deaths are disproportionate in the 65 age group. And one of the major reasons might be the high incidence of non-communicable diseases which the patients have. Mainly the patients have diabetes, chronic kidney disease, chronic liver disease, and other non-communicable diseases that are associated with this. And this is actually showing it beautifully. So when we look at the comorbidities in the total tuberculosis population, it's about 30% of the TB population, but in the 65 plus group, there is about 70% of the patients have comorbidities associated. So that is a huge burden that we have. You will see when we discuss the patient, we have a huge load of patients. And smoking in males is common, alcohol in males is common than this, and underweight is significantly common in this age group as well. So what are the conclusions in these studies? Rapid population is reshaping TB epidemiology. 24% is more than 65. They contribute disproportionately for TB mortality. Diagnostic challenges are a problem, especially when you can see this patient. Even there, where the patient was in a tertiary care hospital, the patient was not appropriately diagnosed. And unfortunately, most of them are treated as bacteriologically not proven, clinically diagnosed tuberculosis, which might actually put a higher burden of tuberculosis unnecessarily. They might have other diseases that might mimic tuberculosis. Hence, sometimes that is one of the reasons that they might have a poor outcome, not properly diagnosing tuberculosis in this age group. Maybe because they are not fit for bronchoscopes, not fit for further investigations, and simply not fit for further evaluation in this patient group. And especially TB risk is high in the elderly population. So that is the important issue that we wanted to highlight during this case. So from now onwards, we will go through the cases very quickly. And then the second case will be presented by Navoda.
Thank you. This one 70-year-old female patient, known patient with hypertension, dyslipidemia and diabetes with mixed deficiency anemia, presented with lower back pain for 3 months duration with bilateral lower limb weakness, but patient could stand with support. And patient had loss of appetite, loss of weight with BMI 14.2. Patient is an unmarried patient, lives with his brother, and she had good support.
So now low back pain in elderly patients, I think Sat and Namal will agree that it's a very common presentation. And sometimes we might just attribute it to the old age, and we might neglect it in most of the things. When the patient comes to the OPD, we might just neglect it. So in these patients, Namal, how would you basically assess the back pain, whether it is clinically significant or not?
Yes, sir. So she has multiple red flag symptoms and signs that warrants further investigation. Given her age, if we go back, she's 70 years. She has diabetes, which makes her more prone to have infections, and had back pain, a new onset back pain for more than 3 months with neurological weakness associated with loss of appetite and loss of weight, which should make us think about malignancy or an infection. So infections like TB, spondylodiscitis, malignancies are either metastasis or myeloma. So just osteoporosis with the vertebral fracture would not cause the loss of weight, loss of appetite. And apart from this, from a geriatrician's point of view, I think in the assessment, given now she has a new baseline functional level, we should document that with her frailty, which we'll come to in another case, from the clinical frailty score, and assess her cognition and delirium, if she has delirium, which again we'll discuss a little bit later. That is quite important in her rehabilitation and recovery, which we'll discuss once we go through the investigation. So she has a lot of red flags in her history, which should warrant proper imaging to come to a diagnosis.
Thank you very much. And as you correctly said, Namal, in this age group, back pain, we should not neglect. Infections, malignancies are common in this age group. So one of the most important things that we have to do is any back pain, obviously, we will take a lumbosacral X-ray in this patient, appropriately covering the thoracic as well as the lumbosacral region, and we can see that the lordosis is absent in this patient, as well as two adjacent vertebral bodies are significantly destroyed in this patient, suggesting an infective origin rather than something else. And in these type of patients, it's always very important to take a chest X-ray. Even the patient comes with a back pain to the surgical ward, please take a chest X-ray. Even though the patient is having a fracture here, maybe see a lung with a secondary might be the cause, and you'll be able to diagnose. And especially in the infective patient like this, one of the major likelihoods is tuberculosis, and this will give us a clue to the diagnosis. And sometimes it will be very difficult to aspirate and get a bacteriological confirmation from the spine. But if the patient is having chest deformities, there are changes, maybe sputum AFP, gene expert, and even a bronchoscopy and BAL will help us to get the diagnosis properly. So chest X-ray is a mandatory thing. And in this patient, Navada, I think we have to go forwards. Yeah.
In investigation-wise, ESR was 87 but came back to low level after that. In CECT, multi-level spondylodiscitis with paravertebral collection was there at the T90, 10 level and L1, L2 levels. And after that, we have done the MRI scan, and that came as infective extensive spondylodiscitis involving several vertebral levels with destruction of the vertebral bodies and intervertebral the nerve compression at the level of L1, L2 levels. And the other investigations, gene expert was detected, medium.
So here, I think I wanted to put this slide specifically. Now, this patient actually was admitted to a medical unit at Teaching Hospital Kalutara, suspecting, as Namal correctly said, identifying the red flag, back pain plus neurological symptoms. They have actually arranged for the CT scan of this patient, not us. So the kudos to the medical team, and they have actually diagnosed the CT changes, and then the patient was sent to us. And then, because of the neurological problem was there, we got hold of the neurologist to see the patient. And then on her suggestion, we transferred this patient to NHSL Colombo at the neurosurgical unit to see whether this patient needs any neurosurgical intervention, because there were neurological signs in this patient. And then they have done the MRI, and there was only a very small collection, 0.5 millimeter to 0.8. It was not amenable for aspiration, and it was not amenable for correction for the, the neurological signs was not explained by this. Hence, they have retransferred the patient back, and then we have managed. Just to say that patient being elderly, coming with chest pain, we just can't neglect the patient. We have to do everything in our possibility in this patient to get a proper diagnosis and have a very proper management plan. Because we didn't have a neurosurgeon at our midst, we had to transfer this patient and the MRI, and everything was done at the proper stage of time. So it's basically a multidisciplinary approach in managing these patients, as most of the patients are, right? And when you look at the main discussion points, one of the most important thing is back pain in elderly should be not only back pain, isn't it, Namal? Any symptom of the elderly patients, which can mimic everything, many things, should be managed in an appropriately structured way. And you will be helping us to identify the structured way. Yeah.
So from Jerry's point of view, while her anti-TB treatment or the disease-specific treatment is going on, we should think about rehabilitating her and getting her back to her independent level. And that's where the frailty assessment and the baseline function assessment comes into play. Also, the cognition is quite important so that she remains adherent to her treatment. She identifies any side effects and toxicities, which she'll be able to tell at least to her caregivers. And we should get involved with the physiotherapy, occupational therapy teams for gait assessment, balance assessments, falls prevention. And almost all our patients have informal carers. That is, their family members are their main caregivers. So as a result, we should teach them about the importance of treatment adherence, bringing them for appointments, and identifying even, I think, treatment-related toxicities as well. We'll be discussing about frailty and delirium assessment in another case. So, yeah.
So thank you very much. So basically, back pain, especially in an elderly patient population, always think about the red flags, especially where there's a neurological deficit. Sometimes the patient might not complain, but proper neurological examination is a very important thing. And especially if it is associated with systemic features like loss of weight, loss of appetite, and low-grade fever, we have to think about infective causes. And in the context of a smoker, or even in Sri Lanka, due to the biomass fuel exposure, Sri Lanka, in females also, especially elderly age, malignancies are common, so secondary deposits as well as osteoporotic fractures, multiple myeloma, we have to consider in this age group. So it's a very important thing that we have to do. And in these patients, however elderly they are, we have to actually go for a timely rational imaging. With our physician's input, we were able to do, and the kindly input from the radiologist. And then microbiological evidence should be sought as much as possible. But sometimes we might have to go according to the clinical picture to start these patients, especially in TB spine and bone TB. We might have to think about the possibilities and then start the treatment while not neglecting the other possibilities, especially in this age group. CA bowel associated with the infective spondylitis might be a feature that we have to look for in certain people. And then neurosurgical and orthopedic referrals to see, and then the nutritional approach. So another common presentation, isn't it? Another common complaint in our geriatric population, loss of appetite. So how would you assess in this patient to see whether this loss of appetite is a true loss of appetite, or whether it is a significant thing, or sometimes whether the patient is saying it's for the sake of saying? Yeah.
Now, in this kind of patient, alongside diabetes, which can cause like gastroparesis and can cause early satiety, drugs like metformin, as we discussed, can actually cause, or should look into those aspects as well. And especially if that is associated with loss of weight, if you can see significant marked loss of weight, then they are more towards the more significant loss of appetite than patient pretending. So at the same time, the patient is having diabetes, maybe sarcopenia. First, we have to overcome this symptom. So anyway, we have to, whatever the food we are going to provide, we have to overcome the loss of appetite. So number one thing is we have to find a cause, actually, what is the underlying cause. Maybe a malignancy in an elderly group, maybe TB. So finding a cause is very important, especially in the outset, in the private practice, in the GP level. And what we first do is we provide small frequent feeds to overcome this loss of appetite. If the diabetes, if there is early satiety, then we have to do that. Patients will not be able to tolerate large feeds like 3 main meals. Instead of providing 3 main meals, what we do is we give about 5 to 6 small meals with energy-dense foods. Now, with that having said, energy-dense foods, some of the energy-dense foods can cause bloating. You must have heard about FODMAP, high FODMAP diet that contains fructose. Certain fructose containing foods like dried food, for example, dates, can cause bloating. Then high fiber containing foods sometimes can cause bloating and cause eventual loss of appetite. So it's important to look into these aspects as well. So certain nuts, again, we can introduce, again, high calorie foods, and yogurts and cheese kind of things. Then dairy products, avocado again with very good monounsaturated fatty acid source with very high calories. Then failing all this, then we move on to oral nutrition supplements. Even though we say milk, they are not actually milks. Most of the nutrition supplements are deprived of lactose. They are lactose-free, gluten-free. So they are nutrition supplements rather than milks. So many people who are having lactose intolerance, there may be chances where transient lactose intolerance may be present in hospitalized patients. So using these may be beneficial in those patients as well. Then failing that, then when we consider about NG feeding, actually, enteral feeding, with the support of kitchen feeds and the nutrition supplements. With that, we try to, depending on the risk of refeeding syndrome, we try to optimize the calorie intake. Gradually, we come up to the 100% calorie intake for this patient. Then next level is, of course, we usually don't go up to that level, is giving parenteral nutrition. Again, high risky procedure in our setup. because in the wards, difficult to do because the nurses are overburdened. They are doing a lot of work at one time. So if you are providing parental nutrition, you have to take all the safety measurements, proper hand washing. Ideally, should have one-to-one care in case of an ICU. So that is supplementary parental nutrition, meaning alongside enteral nutrition. If the enteral nutrition alone cannot meet the actual 100% calorie, the balance we provide by supplementary parental nutrition can be central or peripheral. TPN is ideally, even though we call as TPN, that is total parental nutrition. That term scientifically we use when we provide 100% of calorie through the parental nutrition alone. So this is the kind of timeline rather we use to manage patients.
So basically, when you complaints of a loss of appetite, objective evidence of reduced weight associated with loss of weight, associated with the systemic features will be a very important factor that we have to consider, especially in a patients with tuberculosis and other chronic diseases, isn't it? So that's the first thing. And the second thing, when we are advising the patient on diet, frequent diets, frequent small diets. People think that we have to take a large amount of rice, but sometimes it's a frequent energy-dense diet, depending on whether the patient is having malnutrition or obesity. We might have to decide on that. And the third thing is, if we want to, go for the further things, then we can think about supplementation with appropriate managers. So specifically protein supplementation in a context of vegetarian, and we are not being able to give the appropriate amount of protein, then we might have to go for a supplementation as well. Yeah, thank you very much, Prabhadita. Right, so in this case, I think the most important thing that we highlighted was that basically, it's very important that patients should be assessed in a proper way. Even the patient comes with very common symptoms that are there in the elderly. So we'll go to the next patient.
This one, 71-year-old female patient with known patient with diabetes, dyslipidemia, and hypertension and epilepsy. This patient was diagnosed with bacteriological confirmed pulmonary TB 3 weeks back. And patient came to the surgical ward following accidental fall and found to have a left side base of the thumb fracture. Patient referred to the respiratory team for further management of the pulmonary TB. Patient complained at the ward severe loss of appetite, nausea and vomiting with generalized body weakness and abdominal pain. On examination, patient was ill looking with swollen left side hand, pulse rate BP and within normal limits with low BMI 16.1. On investigations, gene expert was detected at medium and rifampicin resistance was not detected. And AST, ALT are high with total bilirubin 12 and serum creatinine within 49, CRP is normal, and other retroviral studies was normal. Ultrasound scan was done due to AST/ALT was high and that was came as normal. Yeah. In the management, we have withheld the ATT due to transaminitis, and GE referral was done for the further management, and nutritional referral done. Management was 3 main meals with 2 snacks with high protein, diabetic diet with low salt and oil. Vitamin D was given. Endocrine referral was done for diabetic management. Oral hypoglycemics was optimized with the glycoside. And neurology referral was done to manage the epilepsy and adjust the anti-epileptics to non-hepatotoxic drugs. Orthopedic referral was done for the fracture, and geriatric referral was done for further management of the elderly care.
Yeah, thank you very much. Now that this case highlights, isn't it, like the other cases, that how we manage our patients, it is almost like a virtual multidisciplinary care that we try to give to our patients as much as possible. We really don't care how old they are, and even how frail they are to a certain extent, but we try to give the maximum benefit of all the specialties that are there. without any hindrance, and actually the input that we get from them will markedly improve the outcomes of these patients. That's a very important aspect that we have to discuss and tell you, because always get the help from other specialties, because then the patient will benefit at the end. Right. So in this patient, acute liver derangement with anti-tuberculosis, what causes would have contributed was the first question that I would like to think about. So just want to go to the history of this patient. Actually, this patient was having, this investigated for this left side upper zone opacity in a major chest clinic in our country. And basically, this patient was started on a full dose of anti-tuberculosis treatment about 3 weeks back, and was transferred to under our care after with a transfer form. And before the patient came to our clinic, the patient has had a fall about 1 week onto the treatment, and then on the surgical ward correctly, because the patient was on anti-tuberculosis treatment and the patient was having some problems, the patient was referred to us for the management of anti-tuberculosis, and that I think was life-saving. Rather than continuing anti-TB drugs in this patient in the surgical ward, they correctly identified the issue and transferred this patient, referred this patient to the respiratory unit. So whether transaminitis has probably would have been prevented. The patient is probably on an anti-epileptic drug. The patient was an elderly patient, and hence whether we could have been careful in starting this patient on anti-TB treatment before. And right, so acute liver derangement, right? So it is called actually AT-DILI, that is anti-tuberculosis induced, drug-induced liver injury, that is AT-DILI. That is a short term that we use for, and it is one of the most commonest anti-tuberculosis associated side effects, affecting 5% to 33%. We have a wide range, and we will see that elderly patients have more susceptibility to develop anti-tuberculosis associated liver disease. And unfortunately, if we don't detect it at the correct time and stop the drug, one out of 3 will die because of fulminant hepatic failure. So even though anti-tuberculosis treatment is a very good treatment and tolerable treatment, and it will cure the patient, but it can kill the patient if we are not very careful about treating these patients, because the mortality sometimes go up to 35% at 3 months if we don't diagnose it in a proper way. So how do you want to approach? The first is to think about the possibility of this patient developing drug-induced DILI, that is anti-tuberculosis-induced liver injury. So if in our stake, especially in the males, high alcohol intake, if a patient is having high alcohol intake, elderly patients, these patients are very highly likely to develop drug-induced liver injury than other patient or population groups. And pre-existing chronic liver disease, which might not be diagnosed, because these patients might have long-term diabetes with undiagnosed NAFLD, non-alcoholic steatohepatitis. And if we are not very sure, it's always better to, even though most of the guidelines say not to do a baseline liver function in patients who are starting anti-tuberculosis treatment, but in patients in our context, elderly patients having multi-comorbidities, diabetics, it's always better to do a baseline liver function. And retrospectively, if this patient's liver function was done before starting anti-tuberculosis treatment, probably we would have been a little bit careful before starting in this patient. And malnutrition, all of the patients we have described up to now has a very low BMI, and it is a risk factor per se, and low BMI as well. Elderly, older age, this is said 35, this is the South African guidelines, but anyway, especially if it is more than 50 years, the risk is about 3% due to INH only, as well as the genetic status of N-acetyltransferase 2 status also contributing. And then whether the patient is having co-administered hepatotoxic medication. Now, one thing that we have to highlight is the hepatotoxic medication of the patient who has, sometimes in this patient, the anti-epileptic drugs that the patient is taking, we have to consider whether there is a drug interaction to cause hepatotoxicity and convert into a hepatic-friendly drug, which is actually available freely in the government sector now. Levetiracetam is available. And other than that, these patients are usually taking various Kandhavargas, Kandhas, with Monoracudumbia and Heme bovitia. And I have noticed that they have increased liver toxicity. Some of them are taking what we call Sinhala Behet on top of that. So over-the-counter drugs are also, we have to think that whether this patient is taking. So identifying the possible risk factors, especially in the elderly age group, they come into these risk factors. Malnutrition and low BMI is common, as well as the elderly age is common in these patients, and they have polypharmacy. So most of them are at a risk of having liver dysfunction. And thinking about the mortality rate, I think we have to always do a baseline liver function, even though the guidelines in generally doesn't suggest doing it. So because all forms of antituberculosis increase, DILI can progress into fulminant liver failure, and after a certain point they reach the fulminant liver failure. We can't actually reverse. The only thing that we can do is a liver transplant. Other than that, sometimes we can't do anything. And so what are the important aspects? Any patient with visible jaundice, symptoms of hepatitis, fatigability, upper quadrant pain, loss of appetite, pale stools, or with a new rash, because some of these antituberculosis drugs specifically can cause an immune-mediated reactions where the patient can have a eosinophilic blood picture with increased eosinophils and a rash, and these patients can be a manifestation of an early Stevens-Johnson syndrome or a DRESS syndrome, which has a high mortality and a morbidity associated with liver dysfunction. So it's very important that we have to suspect. So in a patient who is in a medical ward or surgical ward, this patient comes and on antituberculosis treatment, complains of non-specific symptoms, loss of weight, always suspect whether this patient is having liver derangement and do a liver function test proper, AST, ALT, total bilirubin direct and indirect, and INR. INR more than 1.5 is a significant factor that we have to look for. So the criteria I will not go into detail. Basically 3 times upper limit normal with symptoms or jaundice, or total bilirubin more than 40, or ALT more than 5 upper limit normal, and or in a patient with already having liver disease, if the ALT is more than twice the normal after starting ATT, we have to suspect DILI in this patient. Right. So the first important, the prevention is always better than cure. Risk assessment, medical history about the drugs and the medical conditions that the patient has. Patient education is very, very important. These patients should be educated that, sometimes what we do is we say the patient where you become yellowish, you become itchy, you come, no, but sometimes these patients, fatigability, unexplained medical complaints, vomiting, right hypochondrial pain, we have to ask the patient to come to us early rather than late, and close monitoring of symptoms, especially in this elderly age group. After the first initiation, about 1 month, we have to bring them closely and then try to assess the symptoms. Early detection is very important. Do the liver functions and see full liver function test with INR in these patients who are suspecting, and unless proven otherwise, stop the antituberculosis treatment. Stopping antituberculosis treatment for 1 or 2 days will not do any much harm, but giving them for the next 2 days might push the patient towards a fulminant hepatic failure. So it's very important. And the other thing is, when a patient develops these drugs, unfortunately, Chamila, isn't it, this reporting is not there in Sri Lanka, the drug-related reporting, so we have to promote that so that we can prevent another one from happening. Okay, the second important thing in this patient, is falls. The patient has fallen. Yes,
I would like to also say in Teaching Hospital Kalathura, we get more false referral from your ward. No wonder why, because there are enough reasons. The most 2 common infections are the older people get chest infection and the urinary tract infection. So when a patient coming with chest infection, they are high risk of getting delirious state because hypoxia, dehydration, electrolyte imbalance. And also the chest condition like tuberculosis, lung malignancies, and interstitial lung disease, COPD, they are very hectic, and sarcopenic and generalized weakness. So they are tend to fall. So I'm happy that you and your team make a routine, fall history in each and every patient whenever you patients over 65. So we get, happily say, we get more falls history from your ward. And why we worried about falls? Because of consequences. It's maybe with a minor injury like laceration, skin tear to life-threatening like internal bleeding and fragility fractures and subdural hematoma. So, and it's not only the physiological deficit when after fall the patient acquired, it's also affect their mental. They are anxious and they are depressed and they restrict their movements, mobility and social withdrawal. So these are the basic consequences that leads to significant morbidity and mortality. So if you see the prevalence worldwide, so when you are passing 65-year-olds, 1 in 3 people will fall at least once a year. And when you are passing 80 years old, then 1 in 2 people will fall at least once a year. So please go back to the slides history. So I'll explain a little bit about the factors that contributed to these falls. If you take our patients, this is a 71-year-old. Please go back. So basically we put, this is a very brief history. We don't include each and every part of this history. And this is a give you room to, think like this history should have been added or this, investigation or the, examination finding should have been added these slides. And what we missing this here is the drug history, which is very important. So it's make you, think a little bit more. So if I'll take this patient as a whole, the diabetes, the duration and the complications are very important, whether it's associated with autonomic dysfunction and the vision and peripheral neuropathy. These are, the intrinsic factor, the patient-related factors. Also, when you take hypertension, again, drug history is important, whether there are multiple drugs which lead to postural hypertension. And epilepsy and anti-TB drugs, there are enzyme inducers and the enzyme inhibitors, right? Sometimes they are, you might adjust the anti-epileptic drugs, which might cause, the fits and the patient after that having the falls. Basically, these are intensive factors. If you come to, there are environmental related factors like we call extrinsic factors. We mentioned here accidental fall. What's the problem is just if you mention the accidental fall, then you overlook that other condition, medical conditions. That's why if you are mentioning accidental fall, you have to mention what is a mechanism, whether it's a slipping or dripping or stumble, Otherwise, what will happen? You easily miss, then it leads to next fall, and this is, then it's a problem with a medical term which we are not evaluated in a right manner. So those are called extrinsics. Basically, it's environmental, there is uneven floors, and there is no crab bars in the washroom, and the cluttered, the distracting way, the path, the walking path in basically. And other factors are like, situational factors like, when the phone rings, the older patient try to, receive the phones and they fall. And, they have urgency with the urinary and the fecal urgency, they tend to, rush to washroom and they fall. These are called the, situational factors that leads to falls in the older patient. And the polypharmacy, the drug is very important. Most of the patients are anti-epileptic, antihypertensive, antipsychotic, the sedative drugs and the, sleeping pills, which again leads them more, the false risk. So the history is very important, and examination also. What we normally do, what I do is normally the postural hypertension is very, important. So you can check the blood pressure in the lying position. Then you are going to check in the 1 minute and the 3 minutes. During that time, if you think after 1 minute there is no postural drop, you think there is, patient is steady, then you can, by that time, you can assess, gait and the balance. Okay, could you please go to that slide? Other slide. So this is, we assess the bedside, that their time up and go test and the gait speed, and also the balance, chair rise test and the standing balance. So normally time up and go test, sort of chair, you ask them to sit and then you ask them to walk 3 meters and turn 180 degrees and ask them to come back and sit. Then you observe. Then we time. Then it should be, there's it should be less than 12 seconds. If you think more than 12 seconds, there is a risk of falls. Also, you can also check the gait speed, like ask them to walk in a normal pace, 4 meter and time. And if it is less than 0.8 meter per second, then there is a risk. These are bedside measurement what used to do we practice. And then please go that. Next one. Then why, as I said, why we worried in older patients this falls? We wanted to prevent the recurrent falls, and because of that, that we can prevent the fragility fractures, because the chronic silent, the disease, non-communicable disease in older people is again the osteoporosis. So they are, risk of they get the fragility fracture. So you can use this Sri Lankan frax model. Then you can apply and see. Then if you think there is a hip fracture risk, percentage-wise it's a more than 3%, or it's a major osteoporotic fractures, is more than 9%. Then you can, I think, straight away, if already they have high risk of recurrent falls and all, you can straight away start the treatment. The available treatment in most of the hospital is bisphosphonate, that is alendronate. You give 70 milligram per weekly. It's like you take the thyroxine the early morning after wake up with a cup of water with the empty stomach, you have to give. And there are, if the we are talking about anti-TB drugs and the liver failure, but you no need to adjust doses, especially in the liver failure or cirrhosis patient, no need to worry. But in case if the patient also have CKD stage 4 and the 5, better to avoid. So alendronate, again, there are side effects like atypical femur fractures and, osteonecrosis of jaw. There are, but don't need to much worry, because these are, you get 100,000, 1 in 100,000. So that side effect should not, make you to prescribe.
Yes, thank you very much, Sat. Now, basically, I think, when a fracture occurs, the consequences might be drastic. Now, this patient only had a thumb fracture, but we know that neck of femur fractures, back fractures in the thoracic vertebrae, as well as SDHs due to impact of the patient's head, have significant consequences. So this patient might come next with this type of a fracture. So these bedside mobility assessment techniques are very important. I think all our doctors should know. At least more than 65-year-old patients coming, do a tug and gait speed. It's very easy to do it in the wards, and at the same time, balance strength and 2 quick tests with, there will be 4-stage balance test as well as chair stand and sit on to stand test. I think these are available how to do in the internet as well. So as a policy, if we can train our house officers who are, patients who are admitted to the medical wards, the geriatric population, at least if we can do this in each and every patient, maybe we can prevent a lot of falls from occurring, not only in TB patients, but other patients as well. So when we come to fractures, the hot topic is Pramudita, vitamin D. So what is your take about vitamin D in tuberculosis and this context?
Yes, now I think it's a good topic and a good time to talk about vitamin D, as I mentioned earlier. So deficiency, as I mentioned, is quite common. So for the calcium and the phosphate metabolism and vitamin D and the parathyroid hormones, they work in harmony for optimizing the calcium in the body. So vitamin D is the first important thing for the maintaining calcium, increase the calcium absorption from the gut. So we use 2 kind of measurements, nanograms per ml and nanomoles per liter, two kind of measurements. Generally, if it is less than 20, certain it depends on the machine actually, the lab and the machine that they use. Sometimes in Sri Lanka, according to some machines, 30, not 20, right? So nanomoles per liter, it should be over 50. So commonly, poor sun exposure, even though we have like 365 days good sunlight, poor exposure to sun, and apparently melanin has to do something, because if you have melanin antagonizes the vitamin D production, 7-dehydrocholesterol activation, melanin antagonizers. So we are having dark skin, so we are running a high risk of getting vitamin D deficiency. And another one is sun avoidance. So generally RDA is around 800 international units or 1000. We usually say 1000, right? So the foods which contain vitamin D are generally foods will not provide the RDA. Oily fish, fortified dairy products will provide, but it will not provide this 800 RDA. So unless the sun exposure is not there, very likely that somebody can quickly go into deficiency. So other limitation is the test is quite expensive. It's about 12 to 13,000 in the private sector. In the hospital also, we are not routinely send patients for it. It may be not nice. Something should be left for an important patient. So what we generally do is, if a patient is having symptoms like for joint pains or hair loss is a typical feature, as we have understood. Anybody who is having hair loss premature, and we do the test, we find that almost like 9 out of 10 people are deficient vitamin D. So go by the history without requesting the investigation, and you can give 1000 international units daily for these patients. And something other than this, since my colleagues have discussed about sarcopenia and the background of liver disease. Now, liver disease is not a contraindication to reduce protein, right? There is only one indication for cut down protein to the best of my knowledge, that is CKD, right? Chronic kidney disease is the only condition where you reduce a little bit of protein, but any other condition, including liver disease, you do not cut down protein. Actually, elderly people, if you have better muscle mass, there are enough and more studies to show that they do better. If they had to undergo a surgery, their recovery is better. In fact, my colleagues would agree. We just put up the cut down for BMI, isn't it, for the elderly people. Usually, it's 18.5 to 25, but for elderly, I think it's around 22. 22 is the cutoff. So better weight, a little higher weight with high muscle mass is always protective. So these are the things that we did during this phase.
Thank you, Pramudita. So basically, the most important thing is one thing, I think two important factors in this case. One thing, especially in a patient who has multimorbidities, risk factors assessed for the possibility of this patient developing drug-induced liver injury, especially in the age group, because it's common. Second thing is assess for fractures and then take appropriate action. So we are in the final stages of our presentation, and we have gone over the time a little bit, but hopefully we'll be able to finish it. Yeah, this is Sarah.
So multimorbidity and frailty in TB and a lone battle. This is a 69-year-old female patient who was diagnosed with diabetes, hypertension, hypothyroidism, and was diagnosed as smear-positive pulmonary TB. And after starting anti-tuberculosis treatment, she developed profuse diarrhea, which was increasing in frequency, and for which we had to stop ATT, and a gastroenterology referral was made, and upper GI was performed, and the biopsy confirmed pseudomembranous colitis. So slow desensitization of ATT was done, and the patient was started on full doses. However, due to the illness, the patient was debilitated, bedridden, and was on a long-term catheter. Talking about the social circumstances of the patient, she was unmarried and living alone, no close relatives to take care of her. There was no one to visit her during her hospital stay, so we had to arrange institutional care for her due to the poor social support for the continuation of ATT. So after a few months, during the second month of continuation phase, the patient was retransferred to our hospital due to altered behavior, fever and dysuria, to find out that the patient was having an AKI on the background of CKD and a catheter-associated UTI. And also the patient was diagnosed with acute cholecystitis during this admission. On examination, the patient was generally ill with a BMI of 15.5 kilograms. Investigations-wise, the renal functions, serum electrolytes were deranged. However, the liver functions were normal. Inflammatory marker CRP was initially high due to the infection, The UFR and urine culture confirmed the UTI, and the ultrasound abdomen showed acute renal parenchymal changes suggestive of CKD. So the management-wise, the patient was on long-term catheter due to generalized body weakness and inability to mobilize. We initially stopped ATT and gradually desensitized her. Nutrition referral was made where 3 main meals plus 2 snacks and high-protein diet was recommended. A geriatric referral was made where HB was optimized and proper hydration and nutrition support was recommended. A nephrology referral for the CKD and endocrine referral for the glycemic control and hypothyroidism management was done. And antibiotics, IV meropenem and IV ciprofloxacin given for the acute infection, the UTI, and was also beneficial of for TB itself. And then electrolyte correction was also done. Blood transfusion was done for the correction of human HB. And the patient was actually retransferred to local hospital for continuation of ATT as AKI settled.
Yeah. Thank you very much, sir. And Sarah, our team of doctors, as well as the nursing team, were completely involved in managing this patient. It's a very, very complicated patient. The reason that actually we are putting the patient's pictures is that to say that there is an underlying person behind this story. And you can see that how, they were really debilitated, they are ill, and, sometimes they tend to be neglected, but, if we have the correct approach, correct attitude, even though the patient is really frail, we can do a lot for this patient. Actually, we have saved almost this patient 3 times, and hopefully she will get better, but that is the story. This patient actually, I think it's a lower GI, isn't it, Sarah? Pseudomembranous colitis, because the patient had basically a bloody diarrhea while on anti-TB drugs, and the patient was developing pseudomembranous colitis, which is rather rare, and we were able to diagnose it with the input from our gastroenterologist, thankfully. And then we slowly started the anti-tuberculosis treatment, and then this patient didn't have anyone at home, unfortunately. This patient was living alone. He is unmarried, no social support. Like the story of many of the patients who are coming in the geriatric population, unfortunately, most of them are now unmarried. Even they are married, they don't have a partner. Their children are sometimes away in Australia or some other country, or else they are far away. They are not looking after these patients. And these patients are debilitated, and they are not looked after properly, unfortunately. And this is a huge problem that we face, because we don't have a place to send these patients home, because we can't actually keep them in our unit for prolonged time as well, because we need the beds to manage other patients. So then we have this mechanism where long stay concept is there, so the patients are managed in peripheral hospitals and send the patient back appropriately when the need is arising. And this patient, unfortunately, maybe due to the long-term catheter, developed acute renal failure on top of chronic renal failure with severe pyelonephritis, and then we were able to manage that. On top of that, the patient had developed acute cholecystitis. And again, you can see that there were multiple specialties that were involved in managing these patients appropriately, and we have to thank them. And you can see that the creatinine was almost 400 in this patient, and even though the CRP was not high, this patient was having a significant renal impairment. And we had to go for various types of inputs of these patients, and fortunately, with multiple inputs, we were able to properly manage this patient in this stage. The second time she admitted and transferred the patient again to the local hospital to be looked after. So I will talk about antituberculous drugs in renal impairment because it's very important, one slide only. And then Pramudita will talk about AKI, and then this is the most important thing, antituberculosis treatment in renal impairment. Unlike in hepatic impairment, isoniazid and rifampicin is basically hepatically cleared, so you don't have to adjust the dose in a patient with renal impairment, especially what we go for by the eGFR, not the creatinine level. All patients, we have to calculate the eGFR, not the creatinine level, to see whether this patient is having basically a renal impairment. So even if the eGFR is less than 30, we can, if the patient doesn't have a liver dysfunction, we can continue the normal isoniazid and rifampicin doses. But when we come to the ethambutol and pyrazinamide doses, we have to be very careful. If the eGFR is less than 30 in these patients, we have to go for an every other day dose. The same dose every other day. And if it is between 30 to 50, That doesn't mean that we have to go for the full doses. Ideally, we can go for the full doses of rifampicin and ethambutol, but with close monitoring of drug levels, which is not available in our context. So in a patient who is prone to get liver toxicity, even there, until the renal functions improve, we might not, even the EGFR is 30 to 50, we might not give ethambutol and pyrazinamide in the normal doses. So that is the most important thing. In AKI, do we have to change anything, Pramudita?
Yes, actually. There is one thing, again, like I have discussed, the kidney disease occurring in any kind of blood count in any patient. You have to be very careful regarding certain things, especially number one, when you are correcting potassium and magnesium on a patient who is having reduced urine output and very high creatinine levels. That can trigger very drastic increase of potassium, serum potassium and magnesium levels, which can lead to fatal arrhythmias. So please be careful when you are correcting magnesium, especially magnesium and potassium on this kind of patients. That's number one. So regarding AKI that this patient had, generally AKI can be divided into non-catabolic and catabolic states. In a non-catabolic state, as you can see, the energy and the catabolic state energy can be slight difference, right? Non-catabolic state, we give 30 kilocalorie per kilogram body weight of the patient, right? If the patient is having edema, again, we will have some trouble checking the actual weight that I have discussed. In this kind of patients, we can use what is called usual weight, the last known weight. It may be more appropriate than the edematous weight that the patient might be having right now, which gives us a false value. So in a catabolic state, especially if the patient, these kind of patients are critically ill, can be they are in the ICU. So what we do is, in the first couple of days, we don't give 100% calorie intake. We only provide 70% of the requirement, and we gradually achieve the 100% during the next couple of days, monitoring the potassium, magnesium, and other electrolytes, right? Again, protein. In a non-catabolic state, protein, we can use 1 gram per kilogram. That is the normal protein intake for any adult, any individual, right? But if somebody is on hemodialysis, that has to be continuous, like regular dialysis, right? Not once in a while dialysis, right? Somebody who is on regular hemodialysis, what happens is, in the dialysate, you lose amino acids. So that's why you increase the protein intake of the patient. It can go up to 1.1, 1.2 grams per kilogram, depending on the dialysis frequency, right? Okay, then catabolic patients, again, need higher protein intake due to the catabolism, to alleviate with the catabolism. So we can go even up to 1.3, 1.5 grams per kilogram. Continuous peritoneal dialysis patients, we even go up to 1.2, 1.8, sometimes 2 grams per kilogram, because that is continuously being, amino acid can be lost continuously. So these are the things that we look at when you have a patient with AKI.
So it should be a scientific approach rather than cutting down protein, and
exactly,
it
yes.
should be tailor-made to that specific patient rather than just haphazardly doing it like that. Okay, so the geriatric assessment of this patient. Namo.
In the interest of time, I'll be very brief. So this is a classical geriatric cascade where she ended up being bedbound on a catheter and had catheter-related complications like AKI and AKI on CKD. And due to the antibiotics and other risk factors, she had C. difficile and as a result had ATT interruption. I won't talk about the delirium and the catheter-related problems. If we move on to the next slide, this is the clinical frailty score, and I suggest to have a look at this. And in our patient lies at level 7 at least. And the other one is not related. It's the delirium assessment tool. It's called 480. It's basically the DSM-5 criteria for delirium. That can be objectively assessed, where you assess the alertness, orientation, attention, and fluctuating course. If we go to the next slide, almost all our patients fall into one of these trajectories in their diseases. They either have an organ failure like CKD, COPD, that they have exacerbations and their function goes down until death, or they're very frail like our patient, and till death they have repeated exacerbations or infections and finally end up in death. So one thing when you're managing a patient like this, if after listening to this patient's history, would you be surprised if this patient were to die in, well, not weeks, but in months' time? Almost all of us will agree that we won't be surprised. And that should lead us to the next slide, which is to consider while managing a patient like this, that some of our patients are not fully curative. They won't come back to their normal level of functioning. So we have to think about maximizing their quality of life, thinking how long is left in their life, and address the issues. I won't go into details, but this is a holistic approach for thinking about palliative symptoms while managing or trying to cure someone.
Thank you very much, Namal. In a very short time, you actually given the gist. So basically, the message that we can give is that tuberculosis in elderly patients can be a cause of frailty, and frailty can coexist with patients with tuberculosis. And especially when we are deciding the escalation of management, the frailty is a very important factor that we should consider. In this patient, even though the blood pressure was low in this patient, very low, and the patient was very sick, whether we would have escalated the patient into ICU, probably we would have not, considering the patient's frailty, but that doesn't mean that we have to restrict the ward-based maximum medical management for this patient. So that's a very important thing that we have to do. And this is the last case. Yeah.
So malnutrition, substance abuse, and social deprivation complicating tuberculosis. It's a 67-year-old previously unevaluated drug-addicted patient. Initially presented to medical ward with cough, fever, loss of appetite, loss of weight for 4 months duration, and finally found out to be SME positive for pulmonary TB. On examination, the patient was emaciated, rather stable vitals. BMI was low, 13.8, with poor oral intake. Investigations wise, the liver functions were markedly deranged by the mid-course. And then hepatitis B, C, serum ceruloplasmin, the etiological investigations for increased transaminases were negative. CRP was elevated, ESR was elevated, serum electrolytes were deranged, and then there was pancytopenia in the blood picture. Hence, the patient was started on bridging therapy with levofloxacin and ethambutol, and desensitization of antituberculosis treatment was done. A gastroenterology referral was made for the increased transaminases, but the etiological investigations were normal. A nutrition referral was made due to the poor oral intake, and the patient was not tolerating NG. And initially, parenteral nutrition was considered, but wasn't able to start due to electrolyte derangements. Hematology referral was done due to pancytopenia, and a bone marrow biopsy was planned, but we couldn't go ahead with it. Actually, to talk about the social aspect of the patient had 2 children who never visited him during the hospital stay, and the wife was bedridden following a CVA. So we had to arrange a local hospital for the continuation of antituberculosis treatment for this patient.
Thank you, sir. Now, again, highlighting the important fact, 2 children were there. They were not looking after the parents. And this patient was actually telling us, pleading with us, even though he was severely ill, so that he can go home to look after his sick wife, because there was no one at home to look after the wife. And you can see that this patient even couldn't stand up from the bed. So we had to have a compromise for this patient, and we have explained to the patient, and we were trying to get the social support. And at least for the patient's benefit, we actually abandoned the idea of sending the patient to the local hospital. We were trying to get him back to the normal state and send him home to look after his wife, even though how practical it is not very clear. But unfortunately, while in the ward, after about 1 week, the patient unfortunately succumbed to the disease. So this is a very unfortunate story, and most of the patients with tuberculosis goes through this story. So, right. So discussion points, substance abuse. I will not go into detail, especially in male patients. Alcohol is one of the most important things. Illicit alcohol is one of the major important things which can cause liver disease as well as peripheral neuropathy in these patients. Socioeconomic challenges are massive in patients with tuberculosis, especially in districts such as Colombo as well as Gampaha, and some even in peripheral districts where social supports are very minimum for these patients. Sarcopenia and malnutrition, I think Pramudita will go ahead and discuss. But before that, in a geriatric assessment, Namal, what are the important things that we have to look for in this patient?
I think the main headings are, as here and Dr. Pramudita will discuss about refeeding syndrome. A patient with substance use, they come with a stigma to the both from the medical staff as well as from the family, and they are very high risk of delirium, both due to the substance abuse as well as their possibility of withdrawal. I've listed the possible causes of pancytopenia in this patient, but I think it's fairly academic, and he was very frail and passed away. And as you very correctly said, who will supervise anti-TB treatment if he goes home? Who will bring him for follow-up? Who will support his bedridden wife? Does he have the capacity to discharge and go home? Even if he has the capacity, would we allow a patient with TB who's still having active disease to go home? And will he, if he was alive, will he end up in institutionalized care or a nursing home? Are the things that we should think. And this patient again is at high risk of a C. difficile infection. So those are the broad areas that I would think of him if he comes to me in my practice. Right.
So, Namal, thank you very much. I think because our president is also here. Now, in the elderly age group, we are facing a huge problem, not only in tuberculosis, patients with chronic diseases, regarding the lack of a proper social structure to support these patients. And I think there are many enough. Now, most of the patients, only 2 of them had good family support, and 3 of them actually didn't have any family support at all. So I think we have to, as colleges, we might have to work together to come into a good understanding and probably have a framework of managing these patients. So would you like to talk about a little bit of delirium in this patient? Because he was having features of delirium.
Yeah. So I'll just highlight the fact that if you look at the hypoactive delirium, it provides more mortality, it's less reversible, it makes people stay in hospital longer, has a lower quality of life, and they fall more. So if you consider hyperactive and hypoactive delirium, the hypoactive version is worse and causes more deaths. So we tend to recognize hyperactive delirium more, but hypoactive delirium and the mixed type is the most common of the 2. That's what I want to highlight. And if you go to the next slide, the things that we do in our patients and we look for in our patient to reverse as much as possible delirium are listed. They're self-explanatory and they're available on internet. But please think of delirium, screen for delirium, and try to reverse delirium as much as possible in any older patients in your wards.
Yeah, I think one of the things that we might miss, Namal, isn't it, in our medical wards or in our wards, is that a patient who is agitated will get the attention because of delirium, but the silent patient who is just not responding, just there in the bed, even though the patient has delirium, we might miss the patient and we might not look for the causes that are, curable or treatable. Maybe a UTI, maybe the cause, or an electrolyte imbalance might be the cause. So we might not be able, or maybe a withdrawal from substance abuse, maybe. So we are sometimes missing these patients, and it's very important to think about the delirium, the hyper as well as the hypoactive patient in many patients, including tuberculosis patients. Right, sarcopenia, Pramudita, common?
I think with the interest of time, I will be very brief. So as my colleagues explained, the biggest issue is fractures, quite common. Again, what we do is we increase the protein intake, as I explained earlier, and mobilization, not only providing more protein intake is, but the adequate physical activity, what we call static exercises while on the bed. They can, if the patient is mobilized, can walk inside the ward, and there are some thigh exercises, pressing the foot end of the bed, and if you get a bed sheet or something rolled and keep it under the knee and press that towards the bed, that again with exercise that you can do. So high protein is not only important, but providing high protein coupled with high calorie, both are important. So this is like basic principles of managing sarcopenia nutritionally. With the interest of time, I will. I think
basically, high protein diet is
yes,
the most important thing.
Not only high, but high
yes,
calorie as well.
High protein and high calorie diet.
Yeah.
So when, as you said previously, frequent high protein, high calorie diet for our patients. Yes. Yeah. Would you like to go through this? Assess confirmed severity, normal, or assessing sarcopenia? Yeah.
I think in the interest of time, so we have to think about sarcopenia in terms of, so with regard to this patient, he definitely has sarcopenia. We won't go into details on like quantitatively measuring and confirming. The treatment or the interventions, as Dr. Pubudita mentioned, are the same. And these are slightly more academic versions. So in our patient, he definitely had sarcopenia and required nutritional interventions to reverse that.
Yes, thank you. So I think at the end, I think we are clear that why we discuss tuberculosis in the elderly. One of the most important aspects is that unfortunately older adults are more susceptible for tuberculosis because of the immunosenescence and multiple comorbidities, non-communicable diseases that are associated. They have a high degree of reactivation, possibility of reactivation, contributing currently for the 25% of the tuberculosis patient load in Sri Lanka. And the second important thing is they are delayed diagnosis than the other people, and they are treated as clinically diagnosed tuberculosis, mainly because of the atypical presentations and reluctance for further investigations and management, and multiple diseases will complicate so many things. Some of them are going for multiple clinics, and hence they will not be able to tolerate these investigations in a proper way. And then specifically multiple comorbidities, the elderly population, as demonstrated by most of our patients, at least has malnutrition and low BMI on top of many other liver, renal, metabolic diseases on top of that, as well as the most important thing is the psychological as well as the social complications of the disease that the patient had, demonstrated by the last patient, unfortunately. And and it causes poor treatment outcomes. Majority of the patients, 75% of the patients who die with tuberculosis are more than 55 years. So, but some of these deaths can be prevented. And unfortunately, we have to have the correct outlines. So, not only that, when we look at the country, one of the important aspects that is pulling down our health statistics, health, what you call this assessment ranking, is tuberculosis, because we have poor outcomes in the patients. So, because until we address the elderly tuberculosis as a country in a proper way, we might not be able to improve the treatment outcomes of these patients. Hence, our statistics and the outcomes and the measurement criteria will remain low, unfortunately, even though we have a very good healthcare system in Sri Lanka. But tuberculosis is the one thing that is pulling down. But I think rather than a country, when we look at a person, this is a beautiful picture actually, which was taken in our TB segment, and I think photographer is just right to me. So basically this patient, you can see, for us it might be, sometimes it might be considered as a statistic of a fall, statistics of a tuberculosis patient, but this person, this mother, is a wife of another person, maybe they are coexisting together in a beautiful way, lived for about 50 years marriage, and they mean so much to each other, and is a mother of a child, and there are many, many social connections that are very important in this group. So this elderly population, even though, we might think that they might not need, but they need the same amount of care as well as the facilities that we have, not just to bring down the TB statistics in Sri Lanka, but to improve the personal well-being of our group of elderly people as well. So finally, I think I have to thank several people. One thing specifically, the Sri Lanka College of Geriatric Medicine, together with Sat and Namal. Thank you very much for initiating this. And Sat was a trailblazer in initiating the first one. Thank you, Sat. And then our nutrition team, I think you are doing daily ward rounds in our ward, not only managing tuberculosis patients. They are doing a brilliant job, and thank you very much. And with your input, we are able to manage. My other consultant colleagues, as well as medical officers in Teaching Hospital Kaluthara, gastroenterology, neurology, orthopedic surgeons, physicians, everyone comes into the picture when we are managing these type of complicated patients. We had not to forget the radiologists, actually, because we are helping us in immense ways in managing cardiologists as well, managing these endocrinologists, managing these complicated patients in the most appropriate way, and helping them come out. And my ward, actually, Ward 25 and 26 respiratory unit, this is our logo, actually created by our Dr. Sitara, who is actually our district she was with us. She's our district tuberculosis officer, and with the help of her daughter, he created this logo. And respiratory unit, Teaching Hospital Kaluthara, hopefully is a fun place to work, right? And we have this team. Unfortunately, we don't have Gavitra as well as our chest clinic doctors in this picture. Yes. And but Navoda joined us recently, so this is after our geriatric college session in the Kaluthara. So we are having this nice working group, and each and every one of them have contributed immensely to the patient care, together with the nursing staff, to the junior staff, the radiographers, the pharmacists. So ambulance drivers, the peripheral hospitals that the patient have been helped. So this is basically a very important multidisciplinary care. And if we work together in tuberculosis, especially in elderly, I think we can actually do a lot of things. So hopefully the colleges together, we might be able to devise mechanisms to improve outcomes of our patients with tuberculosis, especially in the elderly age group. Thank you very much. And if there are questions, we can answer. But in spite of time, no. Do you have any questions? Yeah.
The last words from our side. The journey not yet finished, because maybe when the microbiological evidence is no more there, the chest part is over maybe, but the geriatric care continue, because there are TB, post-TB complications like fibrosis and bronchiectasis. So still journey. Thanks a lot.
So good afternoon. Of an interesting session on some wide and varied presentations of tuberculosis, as well as complications when it comes to managing tuberculosis in older adults. So on behalf of the Sri Lankan Association of Geriatric Medicine, I would like to extend our heartfelt gratitude to everyone who contributed to today's session. First, a special thank you to our expert panelists and presenters for sharing their invaluable insights, especially to Dr. Niranjan Disanayaka, consultant pulmonologist, Dr. Pubudita Veerasinghe, consultant nutrition physician, Dr. Namal Veerakone, and Dr. S. Satganagan, acting consultant geriatricians, Dr. Sara Pereira, and Dr. Navoda Jayasekara, postgraduate diploma trainees in tuberculosis and chest diseases. I would also like to thank Mr. Nalina Vanasinghe and the team from Impress Events for the AV support, the admin staff from the college, Dr. Monasha and Mr. Rohana, as well as the staff here at ClinMark. We are also very grateful to the sponsors of today's event, Cadila Pharmaceuticals Limited, Searle Pharmaceuticals, as well as Getz Pharma. And thank you all for your participation, both physically as well as via Zoom. I would just like to remind our participants, in order to obtain your CPD points, there is a Google form to fill at the end of the Zoom link. Please fill it in, and your CPD certificates will be emailed to you. So before wrapping up, I would also like to invite Dr. Chamila Dalpadatu, President of the Sri Lankan Association of Geriatric Medicine, to hand over the certificates of appreciation to our speakers today. Dr. Niranjan Disanayaka, Dr. Pubudita Veerasinghe, Dr. Namal Veerakon, Dr. S. Satganagan, Dr. Sara Pereira, and Dr. Navoda Jayasekara. Thank you very much.